Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. In today's class, I'm going to speak briefly on Babinski reflex. Babinski reflex test is commonly done in the neurological examination. It is a part of the neurological examination. It is carried out in every patient. This is a simple test that does not require any costly equipment, nor the patient's cooperation. This will give you the integrity of the corticospinal tract that extends from the motor cortex down to the anterior horn cells, which constitutes the upper motor neuron. And the fibers from the anterior horn cells down to the neuromuscular junction, they are described as the lower motor neurons. So Babinski reflex gives the evaluation or integrity of the corticospinal tract. When you stimulate the lateral border of the zone, the afferent signals are carried to the S1 segment of the spinal cord through tibial nerve. Okay. That is tibial, ultimately sciatic nerve carries the signals to the S1 segment. And the result is myotome of the S1 segment is stimulated. That causes the contraction of the gastrocnemius. Okay. Once the gastrocnemius contracts, what will be the result? There will be flexion of the toe and flexion of the rest of the toes and plantar flexion of the foot. This is the normal response. Okay. When the corticospinal fibers are injured, the inhibitory effect of the corticospinal fibers on rest of the spinal segment is lost. So when you stimulate the lateral border of the zone, the stimulus extends beyond the S1 segment to involve the lumbar 5 and lumbar 4 segments. The sensory signals, they stimulate the L4 and L5 segments. The result will be the alpha motor neurons that run from the L4 and L5 segments. They run in the peroneal nerve, ultimately cause the contraction of extensor hallucis longus and extensor distributorum longus. Then what will be the response? The result will be dorsiflexion of the toe and falling of the rest of the toes. Okay, this is said to be positive Babinski reflex. In brief, this is what it is about the Babinski reflex. Then let us see what is there inside. Babinski reflex, it was first described by the neurologist Joseph Babinski in 1896. Since then, it is used as a part of the neurological examination. As I said, it is a simple test that does not require costly equipment or patient's cooperation. What are you doing? Stimulation of the lateral border of the zone will elicit the response. Okay. The test is said to be positive when there is a dorsiflexion of the great toe with fanning of the rest of the toes. Okay. This is the reflex test, which does not require active participation of the patient. Patient can remain well relaxed and you can perform the test. Well, the objectives of today's lecture is to know how to perform the Babinski test, which I already told you. Describe the anatomical and physiological pathways. You try to understand these anatomical pathways. And to discuss the clinical relevance of Babinski test. Okay, let us go about it. Anatomy and physiology. Babinski test is a reflex test used to examine the integrity of the corticospinal tract. So that I mentioned already, okay? The fibers of the corticospinal tract have their cell bodies in the primary motor area and innervate the cell bodies of the alpha motor neurons in the anterior horn of the spinal cord. Okay, the fibers of the corticospinal tract are the upper motor neurons, and those of the alpha motor neurons from the spinal cord to the neuromotor junction constitute the lower motor neurons. Okay. How to perform the Babinski reflex test? Stimulate the lateral border of the sole using a blunt object, okay, from the heel to the base of the little toe. So you are stimulating the receptors of the S1 dermatome, which carry the signals along the tibial and the sciatic nerve to the S1 segment of the spinal cord. Okay, and synapses the anterior horn cells of S1 segment only, okay, of the spinal cord, which in turn run in the anterior root of the spinal cord. Ultimately cause the contraction of the calf muscles through tibial nerve. Then what is the response? Response is in the form of flexion of the great toe, well, which is mediated by the S1 anterior spinal root and the tibial nerve. Okay, because the tibial nerve through the anterior S1 segment, which arises from the S1 segment of the spinal cord, cause the contraction of the calf muscle. Okay, so the result will be the curling of the toes with flexion of the great toe, which is the normal response. Okay. Well, if there is no response, its test is said to be neutral and has no clinical importance. But you cannot rule out the pathology. So let us see. The intact corticospinal fibers inhibit the spread of sensory signal beyond S1 segment. Okay. So, because of the presence of the inhibitory effect of the corticospinal fibers, the stimulus is restricted to the S1 segment. Okay. It is not going to spread to any other segment. All right? Yeah. Well, when there is lesion of the corticospinal fibers, the inhibition is lost, and the sensory stimulus, the signals are carried beyond the S1 segment to stimulate the L5 or L4. So the result will be stimulation of the anterior horn cells of the L5 and L4 segments, which run in the peroneal nerve, ultimately cause the contraction of the extensor hallucis longus and the extensor digitorum longus. The result will be the extension of the great toe with fanning of the rest of the toes. So this is the physiological basis of the extensor response of the Babinski test, which is said to be positive and indicates the injury to the corticospinal fibers. Well, look at this. Babinski sign occurs when the extension of the great toe and fanning of the other toes occurs when the lateral border of the sole is stimulated. This means there is spread of sensory stimulus beyond S1 segment to involve, this is a mistake, L5 and L4 myotomes. Okay. Well, if corticospinal tract is intact, this will not happen. Okay. The sensory stimulus will remain to the restricted to the S1 segment only. In the absence of corticospinal tract inhibition, this is going to spread and involve the L5 and L4 segments. Babinski response is extensor, it is extensor in the infants till the age of 24 because corticospinal fibrous myelination is incomplete till the age of 24 months. The same way, the Babinski is extensor in the individuals during sleep and also the persons in coma. Then what are the indications? The Babinski sign is commonly performed in all the patients in the clinical examination of the central nervous system. Well, any suspected injury to the neuraxis from cerebral cortex to the level of the spinal cord, it is going to be positive, resulting in the extension of the great toe with fanning of the rest of the toes. So, as I told you, Babinski test is to be administered to assess the integrity of the corticospinal tract. As this is the early indicator of corticospinal tract dysfunction in stroke or spinal cord injuries, this test to be performed in all the patients with the neurological manifestations. Well, contraindications are very few. If there is an infection at this on the sole at the site of stimulation, in these situations, you use the alternative method. Like you have got the alternative methods we are going to touch in the next slide. The equipment is commonly used with any blunt object. You can use the reflex hammer, it's a dull point, or you can use the tongue depressor, or you can use just tip of your key. Preparing the patient, ask the patient, remain relaxed, explain the patient about the test, and he should also be explained that there could be some discomfort at tickling sensation when the test is performed. Technique. The instrument to elicit the reflex is run along the lateral border of the sole from heel to the base of the little toe, and also continue dragging on the metacarpopharyngeal prominences to the base of the great toe. Sometimes it is not done, it is done to the base of the little toe only. So some books describe to continue the stimulation arching to the base of the great toe. So you can do any way you like. So alternate methods are, they are used when there is excessive withdrawal response or there is infection at the site of stimulation. These include Chaddock, Gordon, and Oppenheim's. In Chaddock reflex, stimulate the area below the lateral malleolus. It also corresponds to the S1 dermatome. Gordon is by squeezing the tendo Achilles. Okay. Oppenheim's stimulating the area over the shin of the tibia. These are the alternate methods when you cannot perform the classical Babinski sign when there is infection at the site of stimulation. When there is a dorsiflexion of the great toe with fanning of the other toes, indicates positive Babinski. Babinski reflex is negative, the response is flexion, which I told you already. Absence of any movement is considered neutral, but this cannot exclude the pathology. Well, in comatose patients, what is the response? They usually present with the triple flexor response, okay, which includes dorsiflexion of the ankle, flexion of the knee, and flexion of the hip. This indicates gross dysfunction of the corticospinal tract. So what is the difference between triple reflexor response and the withdrawal response? Withdrawal response is variable from time to time. When you repeat the test, it could be not uniform. It is variable from time to time. But triple reflex response is stereotype. It does not change. Well, let us look at some other photographs showing the Babinski reflex. Here is the normal response. The toe is stimulated from the lateral border to the base of the great toe. And you see the normal response is the flexion of the toes as well as the rest of the fingers. In Babinski sign is said to be positive when there is extension of the great toe with fanning of the rest of the toes. This picture also shows the normal response at the flexion and the abnormal or positive Babinski sign with extension of the great toe and fanning of the rest of the toes. This indicates there is a contraction of the extensor hallucis longus and extensor digitorum longus because sensory signals are going beyond the S1 segment to involve the lumbar 5 and lumbar 4 segments because of loss of inhibition of the corticospinal fibers. This is again the positive Babinski sign. This is a Chardak reflex where you are going to stimulate the lateral border of the below the lateral malleolus. Yeah. This is the garden where you are squeezing the tendo-Achilles tendon here and getting the positive response as extension of the great toe with fanning of the toes. This is the Hoffman sign, Babinski of the upper extremity. This is the alternative. That is the equivalent of the Babinski sign that is performed in the upper limbs. When you flick the middle finger and you watch the thumb, okay, there is a adduction of the thumb or flexion or adduction of the thumb. This is a Wattenberg sign, alternative to the main Babinski reflex that is performed in the upper limbs. Well, these are the alternatives for the classical Babinski sign, which are performed in the special circumstances when you are unable to perform the test and there is infection at the site of stimulus and there is an excessive withdrawal response to the stimulus. Thank you very much for patient listening, and we'll meet you again in the next class. Until that time, bye-bye. And my dear students, you could understand the anatomical and physiological basis of this particular test, I hope so, and perform in the patients and improve in clinical skills in order to interpret the functionality of the corticospinal tract. Well, we'll meet you again in the next class. Until the time, bye-bye.